So we heard that costs are an issue. That's why I thought I give you an overview about the cost effectiveness of acupuncture so that you don't have to read 15 really difficult to read papers. And I know when I talk about costs, it often scares people. So they think, oh, cost effectiveness analysis is something so complicated. Health economics can be complicated, but that's mainly the modeling. The cost effectiveness analysis or the economic evaluations itself, they are not so complicated. And I try my best to explain it today in a way that you feel it's much easier to grasp what has been done there and that you really have some numbers which you also can include into decision making. So talking about cost effectiveness analysis, those are usually included into clinical research. So we are talking about original data here. There is one part, which is the cost of disease analysis down here, which only has a monetary side. A monetary side means I only have cost data. I don't have outcome data. So it's a little bit, this is what Jürgen mentioned in the beginning when we have this health claims data. All the other types of analysis have both sides. They have cost data and they have benefit data, so-called outcome data. If something is called a cost-benefit analysis, both things are measured in monetary units. Sometimes the term cost-benefit analysis is used wrongly, but it usually in health economics it means cost on both sides. That's something which is not very often done. Much more often done are so-called cost-effectiveness analysis, and there we have two subcategories. So they all have cost measures and they have outcome measures which are naturalistic, like life years saved, like millimeter Ag blood pressure reduced. Or if we're talking about quality of life aspects, then we have the cost utility analysis, and then we are talking about QALYs which differ between the both groups. Cost minimization, also a subgroup, we only have if we address equal effectiveness. So if we have a kind of non-inferiority study where we want to see if something is just non-inferior, so nearly equal effective, then we would have a look for a cost minimization study. But here, in my talk, I really focus on the cost effectiveness studies and especially on the cost utility analysis. And these are the most common things which you find in the literature. So do we always do a cost effectiveness analysis if we have the cost data and the outcome data? No, because there are some cases where we don't have to do it. We always put costs, this is on this side here, and the health improvement or worsening into a ratio here. So if in our trial we get the result that something is less costly but also less effective, we usually would not include this into our health insurance system. The other thing is, if something has improved health and we save money, we would easily include it. We won't have to check for the cost effectiveness ratio here. So we have more difficult areas. If we have higher costs and we have improved health, then we have to make a decision if these benefits are worth the costs. So these are the typical cost effectiveness analysis here. So when we are talking about QALYs, QALYs is a kind of construct. It's a pretty elegant one because it combines two aspects. We include here the life expectancy and the quality of life. So we have time under some kind of quality combined in a measure. And what you see here is the area under the curve, so it's the quality of life or the utility over a certain time frame. And if we add another treatment, we just get more of it. So that's how you can display these kind of results. So let's put this into an example from acupuncture research. Many of you know that we have done these large studies adding acupuncture in a randomized trial in addition to usual care. These were patient groups up to 15,000 patients per trial, and we came up with having better outcomes, always disease-specific, for those patients who had, in addition, acupuncture. So you see more responder rates in the group who got, in addition, acupuncture. And I'm just taking the example of dysmenorrhea here, and I also tell you that we had additional costs in the dysmenorrhea group, and we have to put this into relation. But before we are able to do this, we have to calculate something from the outcome measure. And this we can do from quality of life questionnaires, like the SF36, for example. And we can just pull out some numbers from there, transfer them in utility values. A utility value is always between 0 here, dead, and 1, total health. So our groups were placed here, the control group, which just had usual care, on 0.68, and the acupuncture group on 0.75. So we have a small difference between the both groups. And this difference is a utility value, and I multiply it with the duration under this utility value. And then I put these things in a very simple formula. I take the difference of costs here between both groups and divide it through the difference of QALYs between both groups. So as said, we spent more money in the acupuncture group, which was around 200 euro here, but we also have higher utility. And when we calculate this, we get a so-called ISA here, an incremental cost effectiveness ratio. What does it mean? I have to pay 3,000 euro to get an extra year of perfect quality of life. That's what it means. It was this black part in the figure which I have shown before, the utility side put together with the financial side, ending into this amount. So when I put this into a chart where I have several diagnoses, this is all data from our trials which I have shown before, you see it's quite low for dysmenorrhea here. It's only 3,000 euro per extra year of perfect quality of life. It's a little bit higher for headache, low back pain, much higher for osteoarthritis here, and a little bit in the middle for the neck pain. So where is our benchmark? Are our benefits worth the money? So we have to have a kind of benchmark. We don't have it in Switzerland. We don't have it in Germany. Usually the UK was good in having it. Do you know where the recent benchmark is? Still the same, okay.
Well, up to 30,000.
Up to 30,000. So, and always it also is a little bit a difference how the currency exchange rate is here. But the UK has 20 to 30,000 pounds. And we have to understand that most additional treatments make extra costs. So the thing we have here is a typical thing you have with a new intervention, with a new medication. You always have to see, is this reasonable to pay this extra amount? So according to these benchmarks, this is cost effective for acupuncture treatment. So now we can do sensitivity analysis. This looks all very easy. I haven't shown you how we do the confidence intervals with complicated bootstrapping and all the analysis behind. But just to understand that the principles are simple, then you have to add a lot more difficult statistics here. So when we go into the sensitivity analysis, these are the benchmarks here, these thresholds. So we have 10,000 euro, 20,000 euro, 30,000 euro. So if our society would be willing to pay 10,000 euro per extra year of perfect quality of life, here it would be cost effective if the effect with the neck pain, I took the neck pain trial here, stays over 4 years, over 3 years. It would be something like 60 to 70% cost effective, the probability, if the effect only stays for 1 year. So you can also see with the sensitivity when it is more or less cost effective. You can also do subgroup analysis. And this gets pretty interesting if we take our headache data here from the trials, because we divided into male and female patients, and also for the 2 diagnoses included, the migraine and the tension type headache here. So this line, which looks being very much out of line, so not with a high probability to be easily cost effective, these are the male patients with a tension type headache. When I look into the female patients with a tension type headache, they are much more cost effective here. And it's even different with a migraine. So these are things which we see in our data, but what does it mean for policy making? This is a big ethical question, if you can do anything with this type of data. And it's also interesting when we have a deeper look into our allergic rhinitis data here. We have also done subgroup analysis according to sex here, and as you can see, when we calculate the ISA for male patients, it's not so cost effective. But it gets really cost effective for the female patients. So again, how do we handle this from an ethical point of view? It's not a mathematical problem or a study problem. It's more a problem what the society wants and what the society finds important. So, these were from our trials. There's a nice systematic review which we have done on complementary medicine and health economics, and Patricia Herman was pulling most of the heavy workload here. This were 114 evaluations on complementary medicine overall, all health economic analysis. This included 11 acupuncture studies. And when we have a look for these 11 acupuncture studies, this included some of ours, but also studies from UK and other countries, 8 of those showed additional costs per QALY. And these were ranging between $3,000 and $28,000, depending on the diagnosis and the country where the data was from. But there are also newer data which are from trials published afterwards, and this is a trial which we did in Berlin, and Benno Brinkhorst was the PI on this one, and I'm pretty sure you might talk about the results today, Benno, and I'm only focusing on the health economic part here. This was more designed as an efficacy study, but here we see from a society's perspective, that's all the cost of the society has, including sick days. When you include this data, it's not very cost effective, the acupuncture, compared to a kind of rescue medication for allergic rhinitis. From the third party payer, so the health insurer's perspective, it's still not so cost effective. But that's also was because the trial was in a very much efficacy controlled environment. The asthma data, which we have published later from our routine care randomized controlled trials, you see here, and you see we had additional costs in the acupuncture group, and that's interesting. These were mainly the costs what acupuncture costs. So patients had usual care, acupuncture on top of usual care, and ended up with additional costs. There's some logic in this. But they also had higher utility values. You see here a significant difference for the utility values calculated from the QALYs, and you come up with an ISA between 23 and 25,000 euro here. But then other changes happen. During the trial, it was around 70 euro per acupuncture treatment. Then acupuncture, if it would be covered in the way how these diagnoses are covered, which are reimbursed within the German statutory health insurance system, it's a much lower amount the physicians get per acupuncture treatment. So if I would use this one in the cost calculation, then I would come up with an ISA between 12 and 40,000 euro here. So this also shows that the data, the cost data which you have in, and if it changes, affects your cost effectiveness ratio at the end. And there's another trial. We will have also talk about depression today, and I only want to highlight the acupuncture data here. So that's from youth research, and you can see we find an ISA here for depression and the treatment of acupuncture for depression of 4,500 British pound. So also seems pretty cost effectiveness here for another diagnosis. And there's more complicated meta-analysis from a network meta-analysis, which also included, here's a cost side, also done by Hugh Macpherson and his group. We see for osteoarthritis of the knee here in UK compared to a lot of other non-pharmacological treatments at the end of the better tries with a less selection bias in, they end up with 13,000 British pound for an extra year of perfect quality of life. Here we have cost assumptions of 18 to 80 pound per session. So you see there's already some variance in here, which makes it perhaps a little bit more stable, the result. And also the treatment durations vary because they're different in different trials. And this type of analysis is only summarizing the available evidence. So where do we stand now with cost effectiveness of acupuncture treatment? When we see the comparison to usual care here, we see additional benefits of acupuncture treatment, but we also see additional costs. So that's a point where we have to do a cost effectiveness analysis to get an answer to our question. But within the accepted thresholds, and I now take the threshold from the United Kingdom, because this is the one which is, I think it's really thoroughly used within the UK, and there are no other countries which have these very clear thresholds usually. And if I take this one, then for most of the diagnoses shown here, acupuncture would be considered being cost effective. But I also have to say we have to be careful with economic evaluations, because they are in different contexts. The UK has a different health system than Germany, than Switzerland. You heard about the United States, which is a lot different from what we have here. And the data is from within these health insurance systems. So, and also cost data changes over time. So when we have a cost analysis, which is 10 years old, we might have totally different pricing meanwhile. Then we would have to recalculate some of the data. So we have to take these limitations into account when we judge on this data. And for whom is this data important? It's very important for decision makers, for policymakers, for health insurance companies. But it's often very hard for them to understand these publications. And then when they don't have a threshold, then to make a decision based on this data. So where should we go? I think we have reliable cost-effectiveness data in acupuncture, but we don't have so many studies which have long-term observations. Those studies from the UK, some of them are better. They have even up to 2 years. But it would be nice to see if you have populations over a long time, if you can even at one point perhaps save costs. We have a very heterogeneous context. So we always have to know in which setting a study has been done. Like the efficacy study, which I have mentioned with allergic rhinitis, this might be not the typical thing we have in a practice later. These routine care studies are usually much closer to our practice situation. And then taking up the story about opioids, which is a really big thing in the United States. And we know in Europe we are always a little bit slower when it comes to these developments, and we have less opioid problem than they have in the United States. But here it would be so interesting to see when we focus on different questions in our studies, on other medication use, on cost savings, if we can avoid to use opioid, save side effects and even save lives over it. So we could do cost effectiveness analysis with saved life, for example. But we would have to focus a little bit differently in our trials. So there is data out at the moment, but there are still options to generate more data. And I think we have to do proper knowledge translation here, that this data is more accessible for the policymakers. Thank you very much.